Hello, everyone, and welcome again. We're giving everyone a few seconds to join us from the waiting room. Always great to be here with all of you for our weekly updates. It's actually St. Patrick's Day today. It's a big celebration in Boston, so I hope you're all celebrating as well. And while people join, I just wanted to say that I'm so glad tonight to have a fantastic guest speaker, really senior clinician and researcher, Dr. Kasarskis with us. So if we can go to the next slide. Again, I just wanted to thank Ed for joining us. As I was training in ALS, I would read your papers, and now it's wonderful to collaborate and learn again from you. So I'll turn it over to you.
Oh, great. Thank you very much. So I've been prepped here that we're just going to do a little short, quick tour of where I'm at the University of Kentucky and a little bit about our clinic. Everybody knows about the platform study, so you need no introduction or rehash on that. But from the standpoint of the geography tour, so if we can go to the next slide, I put down, where are we? Because this is always a confusion. I saw this map one time from the New Yorker, I think, and it was a map of New York City, or a map of the world, and it ended at the Hudson River. So we're on the other side, but our Lexington is actually named after your Lexington, just outside of Boston. So actually, the story was this, of course, Kentucky used to be part of the Commonwealth of Virginia. So that's why we are still a Commonwealth. Virginia is a Commonwealth, Pennsylvania is a Commonwealth, and you guys are. And so, we were the western counties of Virginia, and the word of the Battle of Lexington and Concord came here, and they figured, what a great name, we'll name it after Lexington, Massachusetts. So that's how our town got named. So I put in the red box there where we are. We're in sort of central Kentucky, and you kind of see, I don't think my little pointer is working here, but you kind of see that little green diagonal stripe, and that kind of is a border between our central bluegrass area, which is kind of rolling farmland and horse farms, and to the east of that is where Appalachia begins. So we get most of our patients from Appalachia over to West Virginia and Western Virginia, Upper Tennessee, and to some degree to the southern parts of Indiana and southern parts of Ohio. And so the picture on the upper left is actually our main hospital, and it's on the campus of the University of Kentucky, which is roughly about 38,000 total students. So that's where our medical school is, a dental school, a nursing school, and about every other school you can imagine. That's kind of where we are. So our patients who participate in the platform study and our patients who come for clinical care actually travel quite a distance. To the far tip there in the eastern part of Kentucky is maybe about 170 miles, 160 miles. And so there's a lot of physical boundaries that need to be conquered there. So as you might imagine, being an ALS patient in a area of 7,500 miles away, we do not start a clinic in the morning. We're always in the afternoon, just because nobody could possibly get there for an 8 a.m. Visit. So on the next slide, if you would please, I put down, put down some of the people who are involved in the platform study. So Dr. Kumaraswamy down there is a new faculty member who's joined us. And so he is just getting rolling on clinical drug trials, and he's a very accomplished man and trained in Cleveland, went back to India, which is his native country, and of course had to wait for visas, of course, and wait for COVID, and wait for things to come and join us on the faculty. So we're very happy to have him. Emma Hanley next to Dr. Kumaraswamy is our research assistant. So I'm glad we're having it on St. Patrick's Day because she's actually from Ireland, which is kind of cool. So I can listen to her for forever. And Deborah Taylor is one of our senior research assistants and who's worked with me on a lot of different projects, one of which I'll tell you about in the last slide, but she just knows a lot of stuff. So when she talks, we all listen. So our next slide. So I just want to talk to you about a few of the other major emphasis that we have at our center as far as research goes. One of them is emphasis on nutrition in ALS. And most of this has been in collaboration with Dr. Rup Tandon at University of Vermont. We've worked together on many ALS projects. We just have a new paper published in American Journal of Clinical Nutrition, and we are revising a web page that we have dealing with computation of how many calories people need, body composition, and how much fluid people need to maintain their health when they have ALS. The other major thing that we're working on and have for, oh my gosh, for many years is the large family who has the fused mutation. And this is this part of the reason for showing you the map is far western Virginia by the Cumberland Gap is where a family with this mutation originated. And we've tracked them back down to 1820. Now, this is a fairly typical pattern of autosomal dominant ALS for familial ALS, and it runs in the family. But we have several examples of where it seems to have skipped several generations. And so Dr. Haining Xu and Dr. Guo and I are working on a project to track down genes that might modulate the development of ALS. And so this is going along quite well. I will tell you the first family member that I met was actually in 1984, a long time ago. And it took over 10 years before I saw somebody else from this family and managed to piece them together. And I've actually worked with some of Dr. Brown's group to link a branch of the family that his group had actually seen coming from Southern Indiana. So this has been kind of a labor of love to try to figure this out in terms of genetic abnormalities. So we're making good progress on that. We'll be, submitting other grants on this aspect. Of course, we have several other projects that are going on, but these are some of the major emphases we have. So I'm going to turn it back over to you, you folks, and listen in and learn something.
Thank you so much. And before we give updates about the platform trial, I just wanted to thank you for all the work that you and your site are doing to enroll participants in the platform trial. And I know that you do a lot of research, and in fact, we have a question here already in the Q&A box for you specifically, since you're an expert in nutrition in ALS. So if you could tell us more before we go back to the platform trial, could you please share your thoughts about calorie needs and fluid needs for people with ALS?
Yeah, that's the big question. We did this study a long time ago, published in American Journal of Clinical Nutrition. And in terms of exactly that, trying to predict how many calories a person needs as their ALS changes. Because when you think about all the different things that change, just stepping on the scale may or may not reflect what your nutritional status is. I mean, for most of us, if you step on the scale and lose weight, you think, oh, good, I'm losing body fat, and that's not a bad thing. But with ALS, you could be losing muscle mass. You could be gaining weight because you might have, edema or swelling in your legs, for example. And it's a challenge to eat. Sometimes if someone is very physically active, you may still need almost the identical number of calories, and it might be really a challenge swallowing. So we have an app that, like I said, is getting updated and revised, but exactly to put in several measurements that are very easy. It's 6 questions out of the ALS functional rating scale: height, weight, sex, and basically that will predict with fairly decent accuracy how many calories you might need. And you find out if someone is advanced, meaning not very physically active, they may not be burning very many calories. We have some individuals who may be confined to a wheelchair, and like a man I saw this afternoon, he's on 24 hours a day non-invasive ventilation, so he doesn't really have to work about breathing, and he certainly is not moving very much. Not very happy about it, but I mean, he is not, and so he's not burning as many calories as many of us are. So these adjustments have to be made, and it's sometimes not intuitive exactly, by our dietitians to be able to sort of scope that out. The new paper that Dr. Tandon and I have just published 2 months ago is looking at body composition, which is a very hard thing to do. But we've managed to come up with 2 equations in order to do that. So again, with few fairly simple measurements, you can get body composition. So why is this important? Well, if you think about why we have body fat, it's not the enemy. I saw a program on Nova where they were, tracking some hunter-gatherer tribes in Africa, and the very slender individuals burning like 3,000 calories every day, and they've made the comment that fat is a precious resource, because I mean it's there to help us out in times of caloric insufficiency, and so these it works that way. So if you measure body fat in someone with ALS and it goes down, that means very simply that they are not getting enough calories by mouth because they're calling on their body fat to bridge the gap. And so, when we start talking about a PEG tube, we get kind of off track when we say, oh, I'm having trouble swallowing, or I'm having troubles with this or that. You look at body fat, and if it's going down, by hook or by crook, you're just not getting enough calories. So we're going to get this into our updated app and kind of, make the argument that I think if we follow people with body fat as part of their measurements during their clinic, maybe that will help explain why a PEG tube is important, rather than say, oh, well, I finished a meal and therefore I'm successful. You may or may not be successful. So, it's a complicated topic, probably a little bit off target here for the HEALEY platform.
No, but it's
trial.
wonderful. It's wonderful to
Yeah.
learn from you. Actually, that's the beauty of having guest speakers.
Yeah. So I mean, we'll talk about that, and about, I think, how we can really evaluate that in real time with our clinics to see whether this really works out the way we think. I mean, the business of the body composition we've worked out very clearly with DEXA scans and stuff like that are really kind of research grade things we can't do in the clinic. But so I think we're confident that the equations are correct, but yeah. How it's going to play out in the lives of ALS patients, I think, is to be determined. So,
and there's a few questions about that. Like, let's say that somebody has ALS now and they come to you and they ask you, how many calories they should consume, I guess. What how do you counsel your patients? How do you help them understand how many calories to take, or if gain weight might help them or not?
Yeah. So I think having your weight stable and or gaining weight preferably, I think is a good metric. Now, don't forget, Sabrina, you were the first author on a very influential paper that showed the body mass index that showed the best survival was actually a BMI of like 30. Our research has confirmed that. It's been confirmed in other populations as well. So a low BMI is, it could indicate just advanced muscle atrophy. But, I think people should not shy away from, carrying along a little extra reserve, a little extra fat, meaning a BMI that's certainly stable or increasing, and maybe even up to a BMI of 30, which of course, for long-term health for most of us is probably not a healthy BMI. But for an ALS patient, go for it. I think that was the message of your paper and one other paper and our paper that we just published. It was been verified in yet another population that's really the optimal BMI for survival.
Yeah, I agree. That was actually my very first research project when I was a resident. And so since then, that's exactly what I tell the people I meet in the clinic as well, to try, there isn't a specific type of food that's helpful for ALS, or a specific supplement or these type of things, but you want to monitor your weight, your BMI, which is easy to calculate, or your doctor can help you with that, and try to essentially, because potentially the body might be burning a little bit more calories than normal. Again, I guess without, we can obviously use all your fancy, sort of formulas and calculations, and that's great. Or we can just sort of increase calorie intake maybe by 20% or so, with the goal of maintaining, if not increasing, a few pounds. Just your app can actually people get access to your app if they want to have more specific, calculations handy on a phone?
Yeah, I mean, once it's revised and updated, I will give you the link to that, just so you can put it on the Neil's, website if you wish, and link to it, because I think it had worked in an earlier form. Our web gurus say it's not up to specs as far as security goes and everything like that. So we just have to get it spiffed up.
That's great. Good. So now I think we can go back to our regular updates, and then obviously we have Catherine and Alison here, but this was fantastic. And maybe if you can send the information for the app to them also, that we can help circulate to patients. And in terms of the platform trial, that you work on many projects, including the platform trial. So at this point, we have been testing 5 drugs, as people who follow this webinar series know. And at this time, we are enrolling for drug number 5, trehalose, also known as regimen E, which is indicated in pink in this graphic. So if you can go to the next slide. We started enrolling recently. So far we've had 15 people who have signed informed consent, and 8 that have actually been receiving drug. As you may remember from previous editions, when people sign informed consent, they go through a series of screening procedures before they actually get the drug. So far we've had 8 people who have been started on study drug or placebo. That's part of the placebo control trial, but there will be an open label extension for those who complete the placebo control trial. And really, once again, we wanted to thank the community, the ALS community, because once again, you are helping us test even one more drug, for ALS. And so that's really amazing to see how people, are interested and want to participate. I do anticipate that that enrollment will go well, because we have many sites available. At this time, if we can go to the next slide, we are opening them up as we go. Right now, we have 18 that are active. That includes sites from the sort of original group of sites that were enrolled in the trial, as well as new sites. So the ones that are underlined, I believe, on the right, are the new ones, the new sites that I joined the trial more recently, so that we can offer the trial at even more sites. So again, 18 are active right now, but we are working hard to activate several more sites. So if you can go to the next slide, you can see these are the next ones that are expected to be activated, but many more will follow. Next slide. This is a way to check your site status online for the site near you. All the sites that are listed are active in the platform because they have been enrolling in the previous regimens, but only the ones that are labeled as recruiting are the ones that are already enrolling people in regimen E. Next slide. Of course, we also continue to give updates about different topics in ALS. And so this is just a plug for tomorrow's update on the webinar about expanded access. So if you want to come back again tomorrow for another webinar, we have this opportunity on the Niels, in collaboration with Niels. I'll be talking with Jinsey Andrews, Mary Sukovic, and very excited to be speaking with Philip Green and Sandy Morris, who really have been instrumental in helping us design and launch expanded access protocols for people with ALS. So that's the registration link there to your right, and everything is recorded and available for later viewing. Next slide. If you have any questions about the platform trial or expanded access, please don't hesitate to contact us. And I'm really excited that Catherine and Alison are here with us every week, and you can contact them anytime for additional questions. And next week, we will be traveling to Florida to meet with Dr. Shah from Mayo Clinic. So we continue with this tour. It's really fantastic. Everyone does, research on a different topic of ALS. It's really great to learn from this network of amazing investigators who do their own research and also participate in the trial. Next slide, which is our last one. As always, feel free to contact us with any webinar ideas or more questions. We do have a recorded webinar on the drug and mechanism of action of regimen E trialos. So that's recorded on our website. If you have questions about the mechanism of action of regimen E, please check out our recording. And with that, I think we can take a look at a few questions that have been presented. One question for you, Ed, actually, that's a great one. How can a diabetic ALS patient handle a high-calorie diet?
Oh, wow. That is a really good question. And that comes up, not infrequently, just because diabetes is pretty frequent. So I think we have to work in close conjunction with the primary care doctors or the endocrinologists who are working with the patient, him or herself. I think the important principle here is not that you're trying to get a high calorie diet in there. You're trying to get enough calories in to meet their energy expenditure, their caloric expenditure, which is kind of what we all are doing, right? I mean, what we all should be doing. But I think what you and I were talking about a few minutes ago was, don't be afraid to put on a few pounds. People rather than overdo it on one end or underdo it on the other end is sort of, neither of those is advisable. But the idea is you really want to match as close as you can how many calories you need with how many calories you're able to take in. And that's kind of where the feeding tube comes in, because if you're unable to safely swallow all the calories that you need, then you need a feeding tube. And I'm always reminded about a interaction I had with a patient and her husband, because this was opening the door in the clinic, and there he was giving her her noontime feeding with the peg tube. And I startled him, and he looked over his shoulder and he says, "I'm just topping her off." And I thought, well, that's kind of an interesting image, because that's exactly what he was doing. She was able to eat what she could safely, and he kind of topped her off with peg tube feeding. And I think one of the major confusing points is that everybody imagines that you cannot swallow and something is somehow tied off and everything has to be through the peg tube. But you kind of just top them off. And the other thing too, as is sometimes it's the hardest thing to swallow fluids like water, or some supplemental liquid. And that's the peg tube is perfect for that, as opposed to applesauce or pudding consistency food, which of course is easier to handle. So one size does not fit all, but that's an excellent question. So, I mean, the diabetic may need to adjust insulin or whatever other therapy they're having based on their physical activity and the amount that they eat. And so again, trying to keep everything in balance is a sensible thing.
Yep. Well said. So I'll take a few questions that are more specific for the platform trial.
Sure.
In terms of sort of the timelines. So first of all, in terms of the estimate of when results might be available for the first 4 drugs. So we presented that at a couple of webinars ago. Maybe we can present it again next week. And we are aiming for top line results late summer. Now for the full study results, it's going to be more in the fall, end of the year, but top line results will be very informative. Top line results basically means, if the drug is effective or not for ALS, and then all the, details will be filled in later on. In terms of people who discontinued the zilucoplan regimen, there's a few questions about that. So I want to take them and also let people know that we already worked with other industry partners to open more expanded access slots for people who discontinued in the zilucoplan regimen when it was closed for enrollment in recent weeks because of futility. So if people were in the zilucoplan regimen, whether they were in the double blind or the open label extension, when it was terminated, I would suggest that you contact your physician and then they can contact us to discuss options for expanded access if that's something that you're interested in. Now, some people might be eligible to re-enter the trial and enter regimen E, and that's great. But for people who are not eligible to re-enter the trial and move on to regimen E, please let us know about, interest, if you have any interest in expanded access. Expanded access is for people who are not eligible for the trial and has far less restrictions in terms of medications that can be taken. So some other supplements like TATCA or phenylbutyrate that can be taken during the EAP, not during the trial itself, but during the EAP, those are allowed. In terms of regimen E, which is the one that's enrolling, it's actually an intravenous drug. Somebody was asking if it's oral or intravenous. So again, I would suggest that you watch the recording if you want to see more about the details, because during the webinar, maybe if we can put a link to in the chat, I think it's already there. We gave a lot of information about the regimen and the schedule and sort of logistics about intravenous infusion. So they can be done at the site, but also we have options for home nursing. So it will be a weekly infusion that can be done at home. So again, if you have more questions, reach out to us, or you can take a look at the recording. There's a few other questions. I know that the topic of nutrition is very important. So somebody's asking, if in order to gain weight, if they eat sort of fried food or kind of high, high calorie food, is that okay with this type of food, or should they stick with more, healthy food?
Yeah. So I think the thing that all the dietitians will advise is, calorie dense foods, so you don't have to chew or swallow or work so hard in terms of swallowing, rather than a light food that is not very calorie dense, you have to swallow more times, which puts you at greater risk for aspiration. And so I think our dietitians, and I'm sure that's the way it is, that I've always heard from everybody, a real calorie dense food. So not to shy away from, what might have been forbidden foods of high fat or calorie dense things. But again, the goal is, like Dr. Paganoni was saying, is to, keep your weight stable or maybe have it go up a little bit. And I think that's probably a reasonable general advice. And the means to the end of, if you need 2,000 calories, how many mouthfuls of food do you need to actually put that away? And if chewing and swallowing is difficult, we have to be practical on how you can do it safely and get the amount of calories that you need. So again, I think communication with your dietitian and your speech therapist who have evaluated you directly. They will give you the best personalized, advice on how to achieve that. And I think that's certainly a reasonable thing. I do hear from patients all the time, the thing that they have the most trouble with are things that break apart in their mouth, like multi-textured foods, crumbly foods. So here in Kentucky, of course, we have cornbread. I love cornbread and honey, and that breaks apart in their mouth all the time, hard to control. So I always kind of joke that they fail the cornbread test. And, they'll have the same problem with chips. They'll have the same problem with salads. So things that are hard to control is difficult. So the real calorie dense foods are probably on the order easier to control.
Yeah. Great. So there's actually a couple of interesting questions about future potential regimens in the trial. Would a specific diet be considered? I mean, I think that's a great thought. I think we would need to, to have the scientific rationale for specific diets to include that in the trial, and also obviously, kind of come up with the regimen, etc. And so in the trial so far, we have been putting drugs that are new because again, obviously, people may not be as interested in doing sort of a special diet that they could do on their own. So again, we need to discuss the best mechanism for testing diets, but I completely agree that, diet is something that we want to look into in general. Yeah. And are there, why are we not studying multiple drugs at the same time in the same person? I would say that, we are allowing participants to take riluzole or edaravone, which are FDA approved. That in the future, if there were other FDA approved drugs that would be allowed in the trial. So again, it's already a combination on top of standard of care. And so I think that, that's important, to consider. And then in the future, absolutely, as more drugs are approved, it would be good to test combination of drugs as well. There's a few questions about other trials, like for example, C9 targeted treatments. I mean, those I think are on the horizon and very, very interesting. I think, they're still in early phase, so we still need to see what the results are, but absolutely there are other trials in addition to the platform trial that are very valuable and scientifically sound. So absolutely, I would suggest that you talk to your doctors about the best options for you. There's also questions about, I don't know if you were at the MDA conference, Ed.
No, I was not.
There was some new data presented by Clean, which is one of the industry partners for the trial, on a separate trial that they did with collaborators in Australia, and they did some long-term survival check. And so I think, as we commented on that trial in the past on this webinar, and I think we even had some of the representatives from Clean on this webinar. I think the recording is still available. And absolutely, I mean, I think, again, we remain highly interested in the drug produced by Clean, and so we will test it in this trial. The Australian trial was small. Nevertheless, it produced interesting data, and now we'll have, again, final results this summer from regimen C in the platform trial, which is great.
Yes.
Yeah. So question for you, with calorie intake, if somebody were to take more calories in, for example, is what would be the goal? Would that be to slow down disease progression or prolonging survival? There's been some data in the mouse model of ALS. What would be your best guess? I know it's hard to extrapolate from mice studies, but
sure. Well, I mean, I think if you think what the goal of good nutrition is for any of us, it's sort of health maintenance, and you're not going to kind of eat to cure a disease or maintain good nutrition to cure a disease. You're going to prevent or make good nutrition to prevent worsening of what's going on. So much of this came from a study during World War II, actually, an experiment. It's called the Minnesota experiment, and where they had young males. Of course, these were conscientious objectors, and young males who voluntarily semi-starved, and so much of these nutritional principles came from that. And you look at those individuals who, after half of a year of semi-starvation under controlled conditions, they lost 25% of their body weight. And oh my gosh, if you just looked at a picture of one of them, you would think, you would swear they had ALS. And the point of the whole thing is that just with lack of good nutrition, you had accelerated fat loss and accelerated muscle loss to just try to survive. And, actually, there were a New York Times author wrote a book about it called The Great Starvation Experiment. And it's not a technical book. It's a book about the men who went through this trial. And the purpose was to see how to refeed them. That's why they did it. But the lessons for ALS is that you don't want to get in a position of starting to break down useful muscle because of insufficient oral intake. So I'm trying to refocus the question. You're not really trying to prevent. You're not really trying to cure ALS or not. You're kind of providing another platform, if you will, so that you could test drugs to see whether the drugs actually work. And so that you don't harm or accelerate the ALS condition because of nutritional insufficiency or dehydration or anything like that. So I realize we're all oriented to try to come up with a treatment and a cure, as it were. This is a component of the whole spectrum, sort of the same line. Like, you don't want to fall and break a hip, because then you still have ALS, but you got a broken hip. So you don't want to fall behind on your nutrition because you still have ALS, and the root problem of difficulty swallowing is still there. So we have to manage these problems and not allow some of the consequences of these problems to take hold. So, if you think about it, how we set the stage for drugs to be evaluated and drugs to prove their worth, or test compounds to be evaluated and to prove their worth, I think that's the orientation that we should probably have. So these are all really super questions, because it's so complicated. I mean, it really is. It really is complicated.
Thank you again for providing even this historical background. I wasn't aware of that particular experiment. I'll check it out. So thanks everyone. I see there's one more question about logistics, regimen E. Again, I would encourage you to watch the webinar, reach out to us, reach out to your site. The regimen does require weekly infusions. There is a window so that infusions can be moved a little bit, but for regimen E, the currently enrolling regimen, it is a weekly infusion. So thank you so much. Ed, any final word or anything that you want to share with us?
No, it's just great seeing everybody, and thank you for the invitation.
Thank you so much, and we'll see everyone again next week. Thank you.
Bye-bye.